Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, No Increased Risk of Second Cancers After Radiotherapy in Patients Treated for Rectal or Endometrial Cancer in the Randomized TME, PORTEC-1 and PORTEC-2 trials by Lisette M. Wiltink et al. My name is Joanne Jang, and I am attending faculty at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. My oncologic specialty is with gynecologic cancers. This study investigates whether or not radiation therapy plays a role in the development of second cancers for patients with endometrial or rectal cancer. The investigators pulled patients from 3 different randomized trials, including the Dutch TME trial for rectal cancer and PORTEC-1 and PORTEC-2 for endometrial cancer. The Dutch TME trial enrolled 1,530 patients with resectable adenocarcinoma without distant metastases. They were randomized to total mesorectal excision with or without preoperative external beam radiation to the pelvis to 25 gray in 5 fractions. PORTEC-1 and PORTEC-2 enrolled patients with high intermediate risk stage 1B to 2A endometrial cancers. In PORTEC-1, 715 patients were randomized to total hysterectomy and bilateral salpingo-oophorectomy with or without postoperative external beam radiation to the pelvis to 36 gray in 23 fractions. In PORTEC-2, 427 patients treated with similar surgery were randomly allocated to receive external beam radiation therapy to the pelvis, as in PORTEC-1, or vaginal brachytherapy using several different commonly accepted radiation dose levels. In total, 2,554 patients were analyzed, with an overall median follow-up of 13.0 years. The Dutch Pathology Registry and Registry of Histocytopathology in the Netherlands, or PALGA, were used to ascertain the occurrence of second cancers for patients in the TME and PORTEC-1 trials, as these trials have been completed. Occurrence of second cancer for patients in the PORTEC-2 trial was collected from the trial database. They employed a competing risk model using death as a competing event to estimate the cumulative incidence of second malignancies. The authors compared the incidence of second cancers in their cohorts with the background incidence of cancer in the Dutch general population as provided by the Netherlands Cancer Registry using standardized incidence ratios. They also calculated absolute excess risk of attaining second cancers in their cohorts compared to the Dutch general population. Overall, the investigators found that 21.5% of patients developed a second malignancy, with the most common types being basal cell carcinomas of the skin, breast cancers, lung cancers, and colon cancers. They showed no difference in the incidence of second cancers between different treatment arms. At 10 years, incidence of second cancers was 15.8% among patients who received no radiation, 15.4% among patients who received pelvic external beam irradiation, and 14.9% among patients who received vaginal brachytherapy, which was not statistically significant. Similarly, at 15 years, incidence of second cancers was 26.5% among patients who received no radiation, and 25.6% among patients who received pelvic external beam irradiation. There were also no differences in second malignancies between treatment groups in the individual studies or at specific sites of the body. In general, patients treated for endometrial or rectal cancer were more likely than the general population to develop second malignancies, with a standardized incidence ratio of 2.98, which translated into 154 excess cases of second cancers per 10,000 patient years. Although the median age of patients in the study was 66, patients that were younger than 60 were more likely to develop a second cancer than patients older than 60, irrespective of whether or not they received radiation. Whereas patients younger than 60 had a standardized incidence ratio of 5.47 compared to the general population, with an absolute excess risk of 151 second cancers per 10,000 person years, patients older than 60 had a standardized incidence ratio of 2.76 compared to the general population, with an absolute excess risk of 163 second cancers per 10,000 person years. This study is interesting because it confirms the finding that patients with cancer are at higher risk of developing second malignancies compared to the general population, and is one of the few to look at such a large cohort of patients from randomized studies and include only patients with pelvic cancers. A large number of other studies have investigated the role of radiation in inducing second malignancies, including a much smaller number that have focused specifically on pelvic primary cancers, such as rectal cancer, endometrial cancer, and prostate cancer. This study is relatively unique in that it shows no increase in second cancers with pelvic radiation, whereas most of the prior studies have reported an increased incidence of second malignancies with the use of pelvic radiation. It is certainly possible that reporting bias may be increasing the rate of publications showing increased second malignancies due to radiation. However, a recent SEER analysis of over 600,000 patients by D. Gonzalez et al., published in Lancet in 2011, showed that of the 9% of patients that developed second cancers, only 8% of those second cancers can be attributed to radiation, and the other 92% are likely due to lifestyle, genetic, or other factors. This study is also different from prior publications in a number of important ways. Many of the prior investigations have used large databases, such as SEER, in order to study larger numbers of patients, or have employed retrospective analyses. This publication used patients from randomized studies, thus mitigating the possibility of confounding, and also included more detail than most large database studies. Unlike most of the prior investigations, this study also employed a competing risk model, using death as a competing event to estimate the cumulative incidence of second malignancies. This is very important since the likelihood of death before developing second malignancies can be relatively high in a cohort of patients with cancer. The use of Kaplan-Meier analyses can overestimate the incidence of second malignancies compared to a competing risk model. There are a few limitations to this study, including the fact that their median age in their cohort was 66, and there is a known interaction between age and sensitivity to radiation-induced malignancies. As a result, the findings in this study are not necessarily generalizable to children or patients in their first 3 to 4 decades of life. Also, only endometrial cancer and rectal cancer patients were included. Patients with other types of cancer or other sites of the body treated with radiation may be more susceptible to radiation-induced malignancies. Finally, as mentioned previously, second malignancies attributable to radiation may only be 8% of all second malignancies, and even with a relatively large cohort of over 2,500 patients, it may be difficult to see a statistically significant difference of the effect of radiation on inducing second cancers. Overall, this is a very well-done study that shows no increased risk of second cancers after pelvic radiation for endometrial or rectal cancer and may provide some cautious reassurance to healthcare providers when counseling patients about the risk of developing second malignancies after pelvic radiation. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.